So it was a 70-year-old man that woke up with ischemic stroke symptoms. He was hemiparetic upon arrival at the outside hospital. His NH was 0. As you can see here, the non-contrast CT was negative, and there's a top of the basilar occlusion with good reconstitution to the left PCA. Upon arrival at Grady, the blood pressure was 140. NH was 5. We decided to take a look. There's rapid fluctuations concern us a lot. We went with a shuttle into the right vert. Here is a glide wire going into the vert and a vertebral catheter. You can see actually that the clot had migrated. So obviously there's this dilemma, should we go after that or not? The clot had just migrated. We know that the patient had good collaterals. So our decision was just to pursue treatment and try to save the visual cortex. We always use a J wire. You can see it's actually crossing the lesion in there. Probably better to focus on the lateral view. This is a Trevo 14 microcatheter. The macro run showed a perfect position, and this is what we started doing after we got comfortable with the small retrievers, which is the push and fluff technique. You can see my unsheathing in there. This is Jay Dolia, who was a stroke fellow, is now at UPMC. Now I'm pushing the delivery wire with my right hand, and my left hand is pushing the microcatheter once we're over the middle of the clot. And then I relax my left hand and push the rest of the device out, and it's deployed. Here's the angiographic view of it. That's the unsheathed part, and you can see the catheter arching. It's because I'm putting a lot of forward in there. As usual, we do a follow-up run to see if there's a perfusion channel. It helps us to understand the location of the clot, but you could see a little bit of a waste where the clot was. This is the blind exchange technique that we recently described. You can see that I pulled the microcatheter out, and then we advance, in this case, a 3-max. The 3-max is longer than the Trevo 14, so it needs to be done in that fashion. It's Raul's invention. We find the wire. It always works. It never pushes the delivery wire because it's contained by the balloon guide or the shuttle. We connect the TUI, as you can see in there, and we advance. Focus on lateral once again. You can see the 3-max coming up. The nice thing about this is that you're anchored, so it's always in the inner curve and it tracks very well. Once we are in the intracranial section, we then focus to making sure that the aspiration devices are properly positioned. You can see Jay preparing our setup, which is 2 vac lock syringes with 60 cc's. And unfortunately, it didn't work well, and you'll see why. And we lose vacuum very quickly once the syringe starts filling up. It's exponentially, you lose the vacuum as the syringe is linearly filled. And you can see the 3-max coming up. We have aspiration at this point, so we want to have clot contact. So we call this the mini pinning. So it's the blind exchange with the mini pinning. We found in our experience, and this was published recently at the JNIS, that this is better than either isolated retriever or contact aspiration. So we pulled it out, and you can see that I get very frustrated, like Italo, with hand gestures, because there's nothing in the syringes, as you can see in there. And I blame the fellow, but I don't think it was his fault, actually. And I decided to just go in again. And that's when you start getting concerned, because you're doing an aggressive distal thrombectomy for a mild presentation. But the decision was to do another pass. You can see I'm going up with the Trevo 14 once again. We have the J wire for safety. And pay attention in the shape. We just straighten out significantly the vessel just with the microcatheter. We basically deploy the same way. In this case, since this is the second pass, the fluffing and the active deployment is even more aggressive. You can see how I'm pushing forward the microcatheter. And now we see a perfusion channel, and you can see a little bit of the waste. Once again, we remove the microcatheter as part of the blind exchange. We then advance. Again, this is the Hawthorne effect. I switch to a Jet D. The Jet D is bigger than the 3-max, obviously. It's bigger than a 4-max, but it's slightly smaller than a Cat 5. And then the decision was to obviously prep the syringes properly so we could have the help of the aspiration catheter, in addition to the retriever, to have a proper maneuver. And then you can see on lateral the Jet D coming. Nice visualization and very nice trackability. And once again, pay attention in the shape of the PCA in there. More or less at this point, we turn our attention to assure that, you see I'm going to open up the aspiration there. And once one syringe is filled, we open the other one up. And you can see that it changes the angle of integration with the clot, sometimes in a favorable way, as you can see it in here. So we have a better chance of engaging the clot in a proper angle. and having the clot contained or pinned by the aspiration catheter. So it's retracted here. It's stretched a little bit. We had to reposition the jet D, but gladly it opened up the blood vessel. And you can see that the clot was in the device itself. The blood pressure was near normal. We typically keep less than 140, and the NH discharge was 1 for the SAR3, and you can see a little bit of staining in the temporal lobe medially, but the occipital lobe is completely preserved. So that was the case.
Thank you. It'd be nice if they could go that quickly, you know, with each pass.
Yeah, that was the real speed. We move very fast.
You don't have pumps in Atlanta?
Sorry, I couldn't hear you.
You don't have pumps in Atlanta? Aspiration pumps?
Well, it's a good question. That's the reason why we have 2. Sometimes we actually stack 3. It really depends. If you have a very large PCA, for example, that can actually lead to a lot of reversal of blood flow, and we want to have extra aspiration power, so we can just keep swapping the syringes. That was actually just a mistake that we did upon prepping the syringe. But the fact is that you add a couple of $100 on top of the procedure if you add the pump. We feel very good about the vacuum syringe. It performs very well, has significant aspiration power, but I think it's very convenient to use a pump, and sometimes in these circumstances it can help, as you saw in this situation.
Do you think the larger lumen of the Jet D was partly what made the difference, or was it the suction? I guess if
So our experience with the 3 Max in that type of occlusion has been really positive, coupled with the small Trevo retriever. We have our paper. We had 60% first pass reperfusion, full reperfusion, and very high rates of first pass successful reperfusion to BR3. I can't remember the exact number. So we have been doing very well. I think in this case, again, I was being observed by the camera, and I knew that I was going to present this case very likely. So I just wanted to use something bigger, and we had it available for a few days, so I wanted to try it. I think if the first pass had proper aspiration, it would have probably taken care of the problem, but certainly a larger catheter that tracks well and gets there is better than a smaller one.
Santi has a question.
Quick question. Do you think, Diogo, that in terms of saving time, is it more efficient to kind of go with the triaxial system at the same time and deploy the centrifugal and have already the triaxial system ready, or do they change in terms of time?
It's a good question. We never measured this properly, but the belief is actually the opposite, at least for us, because you only need to prep 1-2 in a 1-3 way. And you can actually prep the catheter as the device is already deployed with the reperfusion channel. And the second thing is the benefit of having the anchor. So you're always in the inner curve, and it tends to track better as a general rule as compared to going with the coaxial or triaxial system.
But you can also anchor, you can leave the intermediate catheter in the V4 segment and then anchor and then go up at the same time instead of doing the exchange.
True, there are ways of doing it, but once again, the 3 Max is longer than the Baby Trevo microcatheter or the 3014, and you cannot do that with a mini system. Yeah, with a larger system you can do it. Thank you.
Hey, thank you very much.